This is Nursing Uncensored. I'm your host, Adrianne Benning, and I invite you to listen in on conversations I've had with real nurses about the crazy and wonderful lives we lead. This podcast is meant to create laughter in addition to serious discussion, and nothing is off limits. We're always honest, but we're not always safe for work. Please listen responsibly. Welcome to Nursing Uncensored. Hey, I am here today with another member of the Repeat Guest Club on Nursing Uncensored. Renee, welcome back.
Hi, I'm so happy to be back.
I'm so happy to have you. The last time you were on the show, I think, was like December of 2019.
The concept of time.
I know, it's like gone. We're in like
it's somewhere around there.
That was like pre-COVID. That was like the before times. And now we're in the post-COVID era. But yeah, how have you been?
I've been good. I've been very lucky with the changing environment of the world to be able to stay safe and stuff like that. But busy, very busy. Very busy and adjusting to a very new schedule for me.
Oh yeah.
Yeah, so they have they can get into it, but I get to work from home, which as a nurse is
work from home. God, that's like a dream come true for me. Anyway, some people would hate it. I would love it.
Yeah, it's definitely got two sides to it.
So why don't you remind people, or for our new listeners, will you kind of introduce yourself a little bit, talk about who you are and where, what kind of nursing you do and all that good stuff?
Yeah. So I actually I've been a nurse now for 4 years, officially this past July. Yay.
Congrats.
That blew my mind. It passed.
We have the exact same nursing anniversary. I hit 4 years, July 1st.
Mine was July, I want to say 26. But it passed this year without me even noticing.
I know, it happens to me now too. Facebook reminds me usually. My Facebook memories are like, hey. Yeah, we're NCLEX anniversary twins.
So I got my BSN, first time right out of high school. Did my 4 years, got my BSN. And I started in a new grad program and eventually moved into psych. So that process went through starting in substance abuse. And then now I'm in community services with mental health.
Yeah, and I worked for a while with community services. I did home care for people with physical and mental disabilities. And yeah, so it was a lot of ADLs, hanging out, helping with basic life skills. Some of the individuals I worked with even kind of graduated out of the program to being able to live independently with only temporary, occasional services. Yeah, it was really exciting for the people that got to do that because they did really well with it. It was a great transitional program. But yeah, so please continue. Sorry, I totally interrupted you.
I just want to say this before I forget it, because we speak it in an acronym all the time, but sometimes I really have to go look it up.
Okay.
We're contracted with our state's Department of Mental Health, and the contract is an Adult Clinical Community Services, ACCS.
Okay.
Community Services. So it's meant for, we do have young adults too. I happen to have the young adult home in my area, which I love. And so we go from 18 to, I often spend a lot of my time transitioning people into elder services after the mental health services might no longer be appropriate. So we cover the entire lifespan.
All right, cool.
Of people, and they are either in a group living environment that we manage, or they're in a sort of supported housing setting, independently on their own in the community, in their own apartments or their own houses, some of them. But the overarching thing is that they all have some sort of mental health diagnosis that affects some sort of area of their wellness or their well-being.
Mm-hmm.
And our integrated team is I'm the only nurse on the team.
Interesting.
So our integrated team is split up we have, say, 300 plus clients in my area, right? And it's split up between 3 different teams, and each team has a nurse.
Mhm. Okay.
So I oversee directly like 116.
Wow. Okay.
I am not going in to visit them all the time. Like I don't do their meds. I teach people how to do their meds, and
Cool.
I oversee like their care coordination, and we oversee like when they have a medical issue
Mhm.
and that kind of thing. It's sort of like a mixed bag. Like whatever the phone
Interesting.
call is that day is what I'm about to deal with.
Yeah, nice. Well, I remember when I worked in the residential setting with adults, a lot of us went through like a community college med
Yeah.
management program.
Oh,
And
yeah.
so, yeah, so we learned what it took to safely administer medications like in the home on a regular basis.
Yeah.
It
Yep.
would be physically impossible for you to like give every single one of your clients their
Yeah.
meds. I can't even imagine
Yep.
giving how many did you say? 106, 116?
Right? Yeah, 160.
Yeah.
So that's
So
why it's very much, we don't like to say that we're case managers because that's not exactly the role. And there's a different branch of our agency that really is focused on case managing
uh-huh.
people.
Yeah.
But it really is, you're just sort of focused on you're the person sort of focused on their medical well being
Yeah.
and like their
Kind of
health and their,
overseeing, making
yeah,
sure that everything's
yeah.
going
So
smoothly.
they have
Um,
so many people on their team, like for any number of things. They always have like a direct counselor
mhm.
that works with them. Typically, those people have psychology backgrounds, but sometimes they don't. Sometimes they're just people that want to help.
Yeah.
And then we have clinicians, so like master's level social work clinicians that are amazing, amazing, and
Nice.
save my life on a daily
Yeah, you got to give love to the social workers. They don't get enough credit. They are the behind the scenes
basis.
wizards. Like I read some of the social work notes and patient like electronic medical records, and I think I'm exhausted just reading how many different agencies they need to contact, the
So,
level of detail, like the acting as like a liaison between the
yeah.
patient and like their family member and their insurance.
Mm-hmm.
Oh, makes me exhausted just thinking about it. So yeah, that's a job and a half. Shout out to all the social
So
workers.
they're fabulous, and I'm like I've been in psych for a little while now. Like I said, I started in substance abuse dual diagnosis, and then moved into the community setting. But I still rely on them heavily when I don't know how to. A lot of my things is like educating these individuals on like whatever their diagnosis might be. The most common one everyone throws out is diabetes, but
Mhm.
it's really literally anything.
So you're
160 people, so it's just like whatever diagnosis they might get, we try to support them
yeah.
with it and like educate them about it and what it means and what they have to do.
So
So
you
sometimes,
really are using a broad education of knowledge, yeah.
oh yeah, I'm constantly still studying in the sense of like if it's something that I haven't come across in a long time, I have to go back and look it up. But you're sort of that medical resource, and it's like so if an individual has a question or something like that, I get an email, I get a call, you just got to figure it out.
So what does your inbox look like? Do you just have, like, endless emails coming in?
Well, it's been interesting more so working from home. Um, yeah, it's a lot of community, a lot of email and phone call communication. Um, Typically, we all work in an office together, and it's a lot of just sitting around in circles, bouncing ideas off of each other,
Mhm.
like discussing individuals and trying to figure out the best way to approach something with them or to help them or something like that. So right now, that's happening mostly over email and phone,
Mhm.
which has required me to make so many email folders. I can't even tell you.
Yeah, it's a new way of organizing information and thoughts and stuff. So
Yep.
it's been a challenge for me too because even though I'm not working from home entirely, like I still have a hospital job, but COVID has caused like a constant change in policies, procedures,
Oh,
like
yeah.
things that we're expected to know and do. I imagine it's been pretty crazy. How has
Yeah.
COVID, besides working from home, how has COVID kind of affected the way you're
It's
interacting with your
a
clients?
lot. A lot. Well, so first of all, we're community based.
Yeah, so
And
you're literally among tons of
yeah,
people all the time.
and
Yeah.
we had to pull back. And we kind of had to start, even the outreach counselors for a good portion of that time when it was really bad, were only going out for like medical and food to help people, make sure people had food, make sure they had their medicine, make sure they had power, water. Like it was
Right.
all about like it switched from like therapy to constant. Like we're constantly working on their goals. Everybody has like a plan with goals that they set for themselves, and we're all supposed to try to work with them to sort of reach those goals, and that's the progression of their treatment.
Yeah.
Yeah, that went like out the window,
Yeah.
and they were
So
just
now
like,
it's about
nope.
basic necessity.
It sort of became about basic necessity, which luckily our employer is fabulous and adjusted very well to that, adjusted our billing a little bit, adjusted the way we did our notes so that we were still able to show this is the support they need right now. This is, this is what's happening in the world. This is what they need right now. We can't focus on half the things they wanted to do towards their goals were closed.
Right, right. Because a
Um,
lot of times I know we had when I worked with clients, a lot of their goals were like be out in the community, like go to the library, seek interaction with other peers
yep,
and jobs and volunteerism. And these are
yep,
literally things that they're unable to do right
yeah. And then we also couldn't do a lot of the things that we usually do. So we have so many groups and activities and like things just constantly going on. We have one of the roles on each team is there's about 3 peers. And what they are people who have their own history, have their own diagnosis, and have gone through treatment and get certified as a peer specialist.
now.
And their role is to kind of just interact with the individuals without really any of the clinical stuff.
Yeah,
And just
like just
kind
be
of
kind of like a friend, a role
it's not,
model.
they run so many groups, and like we had to stop doing all of those in person.
And think about how difficult it is to, I mean, because for a lot of people, they're doing a lot of like really important work on themselves, their habits, their lifestyle. Now imagine you're having to work on some of the most intimate details of your personal life with someone through a Zoom
Yeah.
call or like a
So like,
telephone call or
I mean, people rallied. I mean, there were so many virtual groups like all day long. I got an email every morning. Here are
nice.
all the groups today for people, and people rallied. But for some people, like the virtual connection just doesn't work for them. So then we're
Yeah.
also then you get into how is this affecting everybody's mental health,
Hmm.
and that is something that like kind of I sort of see this happens in like waves. It's like
Yeah.
some people are good. They were immediately struggling, and some people it took a couple months for it to really hit. Or some people like
Mhm.
right now they're just like, oh, now I'm just dragging. So it's hitting it differently for everybody and differently across the ages too.
Yeah, and so I imagine a lot of people kind of have to, redirect their goals not just because the physical nature of things being
Yeah,
unavailable to them, but also because of the way people are processing things. It's true.
yeah,
Some people were stressed out from the minute they were told that they could. I mean, you know, it's already restrictive enough to be someone who struggles with whether it be physical disability, mental
mm-hmm.
illness. The world is already challenging enough for these individuals. And like there's already enough barriers to happiness and success. And
They
now
all
this
had to be isolated or
yeah.
isolate
Yeah.
themselves and not helping.
And that's just it. Like I've even talked to my partner used to work at a day program and
Yep.
we've talked about how when these services are cut, even due to like funding cuts in Iowa,
Yeah.
our
Yeah.
budgets were just disemboweled practically.
We have
And
day we have day programs too.
yeah,
Yeah.
and it's like this isn't just like a fun thing they get to do on the weekends. Like this is for a lot of people,
Yeah.
this is their social circle. This is their opportunity to work, to
It
interact.
really did happen for, I can say for me, at least two or three of my individuals, that their lack of day program resulted in a hospital
Yeah. Yeah,
because a lot of that was due to age. It was older folks
mhm.
who just can't do this isolation.
Well, and
Um,
I mean, I think about how I feel when I'm isolated, and then you add on top of that I don't know, I feel like a lot and my partner and I talked we did an episode a few weeks ago, and we also talked about how a lot of these populations are hidden from the general
oh,
population.
yeah.
And
I
so
tell
it's
people
this
all the time.
yeah, it's this out of sight, out of mind. And I think it's really important that we have people like you in the
Yeah,
profession that actually, like, I mean, for lack of a better, more blunt phrase, you actually give a shit. Like, this isn't just like you punch a time clock. Like, these are people that you genuinely care about.
oh God, I have to remember to turn my phone off at that.
Yeah, yeah.
Well, I have a work phone, which is nice because I can just like turn it right off because it's funny. Just like a hospital, but a little bit less so because it's not shift based, where it's
Mhm.
24-hour business.
Yeah.
So I have
Yeah.
answered call. Like I don't do work over the phone. I've had employees call me to be like, "Who's on call tonight?" I'm like, "Oh, it's a 24-hour thing."
Yeah.
But I will say like the role for the nursing at least really shifted to like a big focus on our congregate living settings, a big focus on our group homes with
Mhm.
everything that's going on, and like they were like they were zipped up tight. Like you had temperature checks to go in. We check everybody's symptoms every day.
You've
Like we
got
just
to.
like it was so it was literally just me calling day after day. Everybody good? Everybody good? Nobody's sick.
Yeah.
Nobody's going out. Like and it was very hard for all of us because we typically encourage these people to go out, how we encourage them to go to the doctor, we encourage them to go to the ER if they want to, and there was this weird or if they need to, there was this weird sense of like we were pulling back and telling them to stay. And it
Yeah.
didn't feel good.
Well, even I've thought about that. Like,
The
as
nurse
we
from home, nursing from a distance,
totally different.
very
Yeah.
interesting. I was not, I was to go in for emergencies, but I was mostly like guiding the staff that's not medically trained through COVID over the phone,
Mhm.
and they did amazing.
Yeah, because this
Like
is
they did
like the time
incredible.
where somebody gets like a cough and everybody in the room is like, "Did you just
Yep.
cough?"
And then there's a national mask debate, and
Mhm.
there was a mask. We all have to wear masks, and everybody just started wearing them. Thanks,
And
like
a
incredible.
and the mask thing, it really does come down to really just caring about the people around
Yeah,
you.
it was just like cause like our individuals too were trying to we refer to
Mhm.
them. We had to educate them on like wearing masks and having to
Yeah.
encourage them to wear them and wash their hands and try to do it in a sense that also didn't make them afraid.
Yeah.
It's like and they're smart, they know. Like,
Well, yeah, of course. But
they're
you
all
still
smarter. They're all smarter than I am. I'll say that anyway.
wanna
But
you this vigilance to, like, uh, be careful and to because especially in like you said in these congregate settings where you have multiple people sharing the same space it can become I mean one person gets sick it's really easy for everyone to get sick
yeah,
and when you have
yeah,
for any population when you already have like comorbidities and issues
mhm.
against you it can be difficult, and it's scary when you don't wanna just go to, like, quick care or the emergency room because
Yeah.
that's a
That's the other thing is that all of the when you're in the hospital setting, all of those people are inpatient for you. Like they're
yeah,
there. People are in the community. I could say, please go get a COVID test, and they can say, no, thank you.
yeah, absolutely,
No,
and they also
okay,
can they can choose to go out in public if they
exactly.
a lot of people can make bad decisions that then filter or, kinda trickle down to other people
Yeah.
that are around them, so yeah, a whole different set of challenges, it sounds like. My
A
gosh.
lot of advocating, a
Uh-huh.
lot of advocating with them, and then to other people for them. So like people that were going out to the hospital, if they were sending them back, I'm calling the hospital saying, hey, they need a test before they come back. They live in a group home.
Yeah.
Like, and you need to give me that result before they get back. Thank you.
Yeah, it's not like a couple
You would
days
think
after
that
they
that
get
would be
here.
soon. You would think it would be no. It wasn't. No.
No, no, it's not. You'd be surprised the things that you'd think are common
Well,
sense.
there's I really don't fault people because there's just a lack of understanding
Yeah.
understanding of what a mental health group home is.
Yeah. So,
It's
what
like
are some
not
common
that they have
misconceptions?
more. The fact that it's really just their home. It's their home that happens to have staff. And like
Yeah.
there are rules, there's a lot of rules, don't get me
Mhm.
wrong. But they can leave and come of their free will.
Mhm.
Like they do not this the first time I was like advised that they tell the staff everyone's a little bit different, but like they have the right to come and go as they please.
Mhm.
And they are responsible for like keeping their own space. We don't do any physical hands-on care. If somebody needs physical hands-on care, I make a referral and I get somebody in
Sure. So if they need help
there. Like,
with like toileting,
yeah.
bathing, that
So
kind of thing.
like I have a young adult house, so that's never really a concern. And then some of the houses have like older folks in them where they might need a home helping and stuff like that. But that's where one of the misconceptions is it's hard to even get a home health aide in there because the companies look at it and they say, well, that's a staff facility.
Mhm.
They
Yeah.
could do it. No, they can't. They're not trained to. And for a mental health setting, that's not appropriate for staff to be seeing them
Right.
on job. It's not. If I do it, I need to have somebody there with me. Like
Right.
that's how like careful we are around all of that. Like, nope.
Yeah, I think that
That's
there
a big one.
yeah, for
Um,
sure.
physical. We do manage their medication, um, but we cannot force them to take their medication.
Right.
Um, stuff like that. Some of them are not 24 hours, um, and then some of them think that we're attacked. They just sort of think that we're an inpatient medical facility. So they'll sometimes send people back that are not medically appropriate,
Mhm.
especially the older folks. And it's really hard because then there's not a lot of options for those
Right.
for the sort of 50 to 60 mental health patients who I don't know if you remember this, but like back in I wasn't born yet, so don't quote me. So like 70s, 80s, okay.
Uh-huh.
They let a bunch of people out of the state. They let or like closed a bunch of the state hospitals,
Mhm. Mhm.
let a bunch of people out. I have some of those folks in my
Yeah.
home. They have not really ever lived on their own.
Mhm.
They're still very, very institutionalized in how they function and function basically in that group home setting and do not function well anywhere else.
Right.
So it's like we get some of these people who our whole goal, like as an agency and our contract is one, housing first is what they always say. So we try to get individuals into their housing preference because that sets them up really well for the rest of it.
Yeah.
So it's housing first, so I just lost my train of thought.
No, we were talking about
I
uh
do that myself
I mean,
every day.
I do that all the time too. I'll be like, "Wait, where was I going with this?" Um
But it's just for the older folks, they're not gonna some of them are not gonna get out into
right.
their own setting.
And
Or it's not
sometimes
appropriate for them to. So then
right.
that's some where a lot of misconceptions happen, and I have to do a lot of advocating on what our homes are and what they are not,
Right.
and what that person needs.
And sometimes, I've had patients that have mental health issues and then they have a comorbidity. For example, they have diabetes. And diabetes is complicated enough to manage
Uh-huh.
when you don't have, other things that factor into your ability to learn, to task. A lot of individuals with mental illness end up homeless as well.
Yeah.
And then how do
Oh,
I
that's
had a
too
patient.
homeless. Yeah,
Yeah.
there's people who will enroll homeless.
Yeah, and then how do you manage your health issues? And then,
Yeah.
these folks end up back in the hospital again.
So we talked about it before in the last. Sorry, I have a random notice.
No, that's
Um,
cool. That's cool.
we talked about last time how I really struggled with the inpatient setting, both
Mhm.
with anxiety, but like I was frustrated by like my limitations of ability to
Yeah.
help. Really
Oh,
wasn't until I got to this job that I was like, oh my god, we're actually doing things to help people.
yeah.
We're putting
Yeah.
them in housing. Like people, a big one is nursing, those home care nursing services, strictly for people with mental health diagnoses. And let
Mhm.
me tell you, not all insurance companies have
No.
no.
And the fact that
But that's
insurance
something I
companies
advocate for a lot when it's
oh, yeah.
appropriate. We go back and forth between like the people who should take on their meds as part of their role as independents and the people who just really would benefit from that nursing services that would decrease their hospitalizations because they're not going to
Mhm.
take them.
Right, right. Um,
It's not considered a skill to
right,
give medicine.
right.
No,
Right.
whatever.
And it's like it's classified differently depending on where you work because like where I worked, there were certain people that I worked with that they were their own guardians, they could refuse their
Yep.
meds. And then there are other people that are do not possess their own guardianship and they often like to refuse meds, but they can't because of the like
Rogers
people that don't.
Guardian.
Right, like people who don't wanna take their anti-seizure medications or and it's like, no, you really don't have a choice in this circumstance because if you
Medicine
don't
would you
take
do?
this. Yeah, so there are all these challenges that occur anyway, there there's such a vast set of challenges in this setting. But
Yeah.
and that's not to say it's only challenges. There are so many great things to see people succeeding and thriving. Um, I worked in a setting where I worked in a there was like a series of homes in this neighborhood that were all like, they were all roommates. It was like three to
Yeah.
an apartment. And there was this one particular set of roommates that were so fucking awesome together. They supported each other. They did better
Oh, yeah.
together than in any other combination in any other residential settings. And so there can be these like light bulb on, like you see people that otherwise would have difficulty just managing their day-to-day lives and now they're doing so damn well and
Mhm.
they have all these different professionals that they have to kind of interact with,
Yeah.
med management,
Oh,
psychiatry,
yeah.
case managers. it's
Oh, yeah. They're
it's
very busy.
yeah, yeah, and, I think about how I feel just trying to, like, remember when I have a dentist appointment and then having to, like, factor in
Yeah.
all of these other things. Um,
Yeah, well, small things like that is that we try to help them even remember their appointment, and that
yeah.
improves it, by that much that they are consistent with seeing their primary care and they get a physical every year.
That's just it, and then you see these positive repercussions, like, you see greater med compliance, better symptom management, you see people that are able to, like, maintain employment, relationships better because they have these consistent, like, functions in their lives. I mean, who wouldn't do better with, like, consistency in our
Oh yeah,
habits
oh
and,
yeah,
like, and so for you, you get the opportunity to kind of see these things maybe from a bird's eye view in your own
yep.
position. Um, so
And I love getting people doing their own meds. It's something I really push for when it's appropriate and it's a victory.
yeah.
But I also like the my boss will tell you my director of nursing is fabulous. She will tell you in our interview, she tells you your three main job requirements. She lays it right out for you. And the first one is that we actually oversee the beds in the program. We don't give them, but we teach staff how to administer them based on the state program
Mhm.
that's all lined out and a bunch of policies that I have to memorize. And oh, so like
Lots
that,
lots of information,
yeah,
yeah.
that was a big part of it. I didn't think about as a nurse. It's like, oh, I could teach like other people how to do this.
Mhm. Yeah, because
Like,
one of the roles of a nurse is that of educator.
so I teach other people how to give meds to other people. I teach people
Uh-huh.
how to try to take over their own medications, and it's just like so you get to see such progress and like I just didn't see anywhere else.
Yeah, I mean, as a nurse,
Not
I
the way
have a
that like
very.
tangible.
No, but it's true, like, I'm pretty well focused on just the patients I have in front of me in that moment, and then when they discharge, they're gone.
Yeah.
Like, for the most
Oh yeah.
part, I don't get a lot of follow-up unless, I mean, we do have some patients that are repeat patients, but
Oh yeah.
for the vast majority, I don't get that satisfaction of seeing, like, the progress as they get better and better at managing their own health, so.
And I still work closely with hospital nurses all the time. All the
Yeah,
time.
how so? Oh, yeah, like, a lot of that
Oh yeah.
coordinating?
So like if somebody's admitted, I'm typically calling over unless I'm told otherwise. If somebody goes to the ER or if somebody's inpatient, unless somebody has already called, I
Mhm,
call over. I try to talk to the nurse. Um, Especially if it's like a recent example. So like somebody that was having urinary retention.
Mhm.
is what they were reporting. This is somebody who has a history of reporting lots of things that really are typically tied to anxiety and fear around their health.
Mhm.
So frequent flyers to the ER for things. So when they went to the ER, they came back to one of our programs with a urinary catheter in, which doesn't sound like a big deal, but it's not. We're not a medical setting.
Right.
Nobody there could touch that.
Right. So like the patient
So
essentially has to be
he was
managing that on
expected
their
to do
own.
everything. Yeah, he was expected to know when to empty it and to shower.
And keep it clean and prevent
Yeah,
infection
but
and this
then it's like
can
I
be
have to be
complicated.
careful when I speak to them because of their tendency to. So, like, you ever talk to a patient and it's, "Are you in pain?" "Oh yeah."
Uh-huh.
"Does it radiate?" "Yep, it does."
Yep.
You
Yeah. And
know,
you're like, really?
yeah,
Mhm.
and I think it's just because they have a hard time telling you what is wrong.
Yeah. Yeah.
But it's like you have to be. I have to be so careful with this one and just be like, "So why did you go?" But I
Right. A
heard
lot of
I
open-ended
get
questions. Yeah.
so
Mhm.
I get like an incident report when that happens. I get an incident report every time somebody goes out to the hospital. So I get like an incident report, and then I went over to the house to see him. The other talk, I was like, "So like, why'd you go?" "I didn't feel good." "Why not?" And we just
Why
go back and
why
forth.
didn't you feel good?
What did it feel good? And there was like one or two times where I still suggested something, and then he said yes. And I was
You're like, "Oh, why did I say that?"
like, they're okay.
Yeah. And
But
and you have
stuff
to be
like that,
careful.
and I have to go to that appointment now, to go to that
Yeah.
follow up appointment to ask the right questions and to get the accurate report of what is going on with him because he has a difficult time processing it, retaining it, and then giving
And
it
then
back.
sharing it with you. Yeah.
Yeah,
A poor
yep,
historian, as we might
yeah,
say.
that's one. And also, he just will hyper. He'll hear something that he thinks is negative or bad or dangerous, and that is all you hear.
Right. And then everything else is like
Yeah.
blurred out into the background.
And I tell them all the time, I'm like, with these sort of people, I'm like, I get it. Like, it's hard. One big thing, it's really hard to distinguish anxiety from chest pain.
Yeah. Oh yeah.
That's like my number one issue is
Yeah.
helping people distinguish between the two.
And as a respiratory nurse, we have a lot of patients that are like, I can't breathe. And you're like, okay, well, you're satting 100%, but you're breathing 47 times a minute. So the reason you can't breathe is because you are freaking out. I mean, I wouldn't say it to them like
Yeah,
that.
no, no,
Yeah,
it's
you're
because of,
having a massive anxiety attack right now. That's why you can't
yeah.
breathe. But they are really convinced that they are suffocating. But it's like, no,
And they go hand in hand.
yeah,
Because if
yeah.
you like bring yourself up enough, you are going to start having trouble breathing.
Exactly, exactly. So it can be really hard to kind of tease these things apart,
Yeah,
especially when you are not in a medical facility. So you can't just like rip out a stethoscope, start assessing, and like it's a different, you have to remember your boundaries.
it can be dangerous too when people go. It's dangerous on both ends of people who don't want to be seen. So I
Hmm.
work with people who do not like for typically for very good reasons.
Right, right.
Sometimes for not so good reasons, but
Hmm.
typically it's for a really good reason. That they like have aversion to providers, they don't want to go. So I'm working with that, and then I have other people who just don't go to the ER
For
like consistently.
everything. Yeah.
Yeah, are
My tummy
constantly
hurts. Yeah.
calm with things, which is both of that is fine. It's just sort of like you have a very different
You have,
phone call text is very
you're
different.
like, I'd like to get somewhere in the middle of this
Yeah,
spectrum. Like, yeah. And that's a
it's
process too
uh,
of like educating what is an emergency. I mean, I feel like we have to educate everyone about that. What
yeah,
requires going to the emergency room,
yeah.
what doesn't.
And then that switched with COVID. One of the many things that switched.
Yeah, yeah.
It
And
didn't really, but it was like there was a little bit of like, can we call your doctor?
yeah, can we
That
like have a conversation about it before we like head into a crowd of people that are all coughing in a
yeah.
waiting room?
Hmm.
And that's just it as winter approaches. I was thinking, I was talking to Doug and I was like, you know something? I feel like I need to build like a little winter illness kit, like a first aid,
Mhm.
safety, oh shit kit. Because if I get like sore throat, cough, that sort of thing, I want to be able to maintain myself at home for as long as
Yeah.
possible. So it's
Oh
like,
yeah.
have some
No.
Gatorade in the
That's
house,
a,
have a couple
yeah.
extra doses of Theraflu. Like, it's not a bad idea to I'm
There's
not
some
talking
stuff.
like build a bunker, but
Yeah.
have some things so that you don't need to run out. And I don't know, I've joked with Doug. I'm like, in an apocalypse, I should have like some bags of saline and some IV kits or something. But
That was the group I did. I run groups sometimes too. That was the group I did. Was like what you should have,
oh
like
yeah,
your car.
in an emergency, like
Yeah.
what you should have on hand. That's
Hmm.
actually a really great group. I think we all need
I
to
did the
attend that.
hygiene group. Um, at one point that was interesting.
What group?
Hygiene,
Oh, hygiene. Yeah,
washing, cutting nails, shaving skin when needed, deodorant,
yeah, yeah,
hand wash,
yeah.
condoms.
All the good stuff. All the
Well,
from yeah, from
the
A to
stuff
Z.
random, and then there's like random stuff you wouldn't think of, like all of our group homes have sharp containers
Oh
that
yeah.
I have to
Mhm.
round up and bring to our main office to get rid of, and then bring out new.
Yeah, that's like a super important thing. Nothing
Yeah.
pisses me
So we
off
try to keep
faster
that
than a full
stock
sharps
with
container.
stuff. We teach them how to do vital signs. So the same people that do meds can also do vital signs
Mhm,
and blood
mhm.
sugars.
Yeah.
We have to teach them how to do that, and that's yearly. So this year was really weird because the year went by really fast, and I feel like I just trained people I scheduled to train again.
Now it's time to do it all over
I was
again.
like, I can't believe I'm saying this, but it's been a we got to schedule again.
That's how I feel about competency testing. We have like nursing competency testing every October. And this October
Yeah.
is like, we can't, usually we get together, we run fake codes, like we do all this
Oh,
hands on stuff. Yeah. And actually, last year was the first year that I helped like moderate the
oh, fun.
code
Yeah.
scenarios. And that was really cool to see because as a student and as a new nurse, I really hated these simulations because I felt really unsure of myself,
Yep.
really
They get
anxious, like,
panicked and
"What's
think
gonna
about.
happen?" Yeah, you're waiting for, like, the person running the drill to, like, all of a sudden make their heart rate just
You're
go
like, what's
insane.
around here? Is
Yeah,
that
yeah.
something
But
happen?
watching it from like stepping back and watching people and how they interact, because my unit, like I feel like we all know each other pretty well. Like we're a pretty tight staff. And so it's interesting to see how everybody like handles these different scenarios. It was really cool to see. So yeah, it's like being the teacher is a really kind of cool experience. And so I'm sure you get to
Yeah.
do that a
Yeah,
lot.
no, I enjoy it. I like it. It's another thing that's going virtual, so that's going to be weird.
Mhm.
Um,
So how have
so,
your tech skills evolved over this
oh
entire
yeah, a lot of video meetings. But it was nice, like for our agency, it really helped us find ways where we could do things better. Like showed us a
Mhm.
lot of ways that we were wasting our time, and a little
Yeah.
bit like direct ways that we could do things and organize things. I would say I miss my nurses because like I'm the only nurse on my team,
Mhm.
right? So in my area, I have two other nurses that I supervise them, so that's
That's
fun.
cool.
So I do get to see them, but even them, I was just seeing over video.
Yeah.
I was like, the only time we really meet all together is unless it's like a training or something, is for staff meeting like once a month,
Mhm.
and that was happening almost once a week while COVID was happening because we had so many updates and so many changes and everything. And then it just went back to kind of like once a month. And I finally saw a bunch of them when we did some COVID. I was like, people,
You're like, "There they are. You're here. You're real. You exist in like you're 3D. You're not just a two-dimensional character." Yeah, before COVID, I would say to people like,
powerful
"Hey,
nurses.
yeah, I'd be like, "Do you wanna use Zoom?" And they'd be like, "What's Zoom?" And now everybody is like, "Yeah, let's just
Right?
go on Zoom." So, I feel like we've all
I
had to
did
make
have that thought when you sent me the invite. I was like, oh, I got this down this time.
yeah,
I
you're
have it
like,
on my
"Oh, I
phone.
know." Well, now, like, when I interview people, I used to have to say, like, "Hey, the mute button is down in the corner," and now people are just like, "Bloop, bloop, bloop." They got their backgrounds all set up. It's like everybody's ready to go. So,
Mine's just my room, which is a mess.
You know what? That's real life. I mean, you don't want to see what's behind the curtain.
That would
Oh,
be
now
pretty
I've goofed it all up.
Oh, now you did. Now you did it. um,
Nobody needs to see the laundry I haven't folded yet.
but I mean, I keep telling like all my friends because like there's agencies like mine all over the place.
Hmm.
They're all like, a little bit different, but like this setting. I know I live in Massachusetts, which I mean, people are going to say it's because they have poor mental health treatment experiences, and I'm sure they do. But like, I think compared to what I've seen in other states, that ours is pretty good. Um,
Yeah, and
like they need nurses in that community setting. It keeps the people out of the hospital,
yeah,
or it
absolutely.
gets them in there when they need to be, and before it's too late.
And when I was doing my RN to BSN program, one of the things that I had to do was community health project. And the project that I was working on was with a nurse who was doing a fall prevention program for seniors. And that included everything from like going to helping people do like inventories of their homes to find hazards, um, all the way through like doing Tai Chi for seniors. And I did like a balance testing class with them where I was helping run these different stations, helping doing like the get up and go test where you like see how someone does like literally standing up and taking steps after
Oh,
like getting
those
out of
made
the
me
chair.
nervous in the hospital. Slow down.
Yeah, you're like, "Slow down." You wanna make sure they're not just gonna, like because they say that when you're likely to pass out, it's not just you stand up and you pass out, it's usually you stand up, you take 2 steps, and then the tunnel closes, and then you pass
Yeah,
out. So, it's really important to make sure that those safety measures are in place. But, yeah, the point I guess the point of all my rambling about this is that community health nurses do so much to protect people from ending up in the hospital. Like one community health nurse talked about how she had some clients who the entryway to their home was so cluttered that when one of them had a fall and needed to bring EMT, the emergency medical technicians in, they couldn't get in because they couldn't get through the doorway that had all this crap cluttered up in it. So
yeah,
really, these community health nurses are identifying things that hospital inpatient nurses or even clinic nurses have
yes,
zero way to detect.
yeah.
Because I don't when I admit a patient, I don't go, "Do you have a whole bunch of shit in the way so that a EMT can get into your house?" Like, that's not a screening question. So,
But
yeah.
even a testament to you guys, I've noticed that even like when I call, like I could call and speak to you, like if one of my patients is on your unit, call and speak to you and say, like, and I do this a lot. Sometimes I'll say, just so you know, like this is their home situation, and
Mhm.
they could really benefit from like, they might have to be sectioned. We finally got them into the hospital, but they might have to be sectioned because they will not do the follow up that you need,
Right,
and it
right.
will or something like that, or they need a rehab stay.
And as a nurse, I love when I have those
Stuff like
notes
that.
from staff that say like, "Hey, this
Mm-hmm.
person is more compliant if we follow the routine of this, this, and this."
Yeah.
Or like
They just
yeah, yeah.
they go 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 go.
No, sorry, there's like a little bit of a delay. But yeah, you basically you know them better than we do from just like a short inpatient stay.
Yeah. And but like I can hear some of the nurses' frustration that sometimes even when we say these things, sometimes it doesn't make a difference.
Yeah,
Sometimes like, systemically, there's nothing that can change the fact that this person's gonna go home.
yeah, yeah. And
And
that's
so
the hard part.
that's okay. Then we shift our focus, but all right, they're gonna be home. How
So
do we?
what can we do? Right.
What do we
What
do
do we do?
now? Yep.
Yeah. And I feel like nurses of all different disciplines are having to do that. Like, okay, well, that didn't work. What's the next try? What's the next
Yep.
thing we try? And that can be incredibly challenging. It sounds like your job has like all of these different skills that you need to be having in play. Um,
Yeah.
and I'll say this again. I've said this before so many times. There are people that say like, "Oh, if I leave the bedside, I'll lose skills," and I hate that because you're getting a whole different set of skills. Like it's totally
So,
different. And yeah, you might suck at starting IVs if you go back to a hospital setting someday, but the odds are you're not going to do that because you're thriving in what you're doing. So,
yeah, it's not something. I think it's because which is necessary. Training is school is very like clinical based,
Mhm.
like
Oh, yeah.
hospital based, because that's like the top of complexity.
Yeah.
And then it's almost like when you get into community health, you might be talking about something that's a little bit less complex, not necessarily, but like a little bit less complex when you're like at a primary care office or something like that. But like that's not, it was such a learning curve when I started this job. Like you have no idea. I was like, I don't know what to do when somebody's insurance is lapsed,
Mhm.
and they call the nurse for that. You know,
Yeah.
that's not entirely my role, but it's just like things you wouldn't even think of, and the fact that you have such a large number of patients that could come at you with any diagnosis, and you're the person on the team that's going to help them with that diagnosis.
And the lone nurse on your team.
Yeah.
Do you consult with
Oh
the other
yeah.
nurses on
Oh
the other
yeah.
teams? Yeah. Yeah,
All the time.
you're
So
like
yeah.
fellow providers, yeah.
So I consult with even the two nurses in my area that I supervise. I run stuff by them all the time. And then my boss, when I when I really need help, um, and she's great. She always answers. She doesn't care because that's how we're set up. So she kind of like that's the kind of is used to it that we have to call her because we're like in the northern part of the state. She's down near Connecticut, and I need some help.
Yeah.
Then
Well,
yeah, we also have specific people to call for our med program. So in our nursing department, we have nurses, we have LPNs that are at like our day program, our day have stuff, and then we have a children's side, we have developmental disabilities. I am in mental health.
mhm,
There's the and then during the nursing department, we have two people who oversee like our med program overall.
mhm.
And like there's people I call, so I'm like, so is this a med error, or like they
What do I
brought
do
meds
with
in
this?
but they didn't sign them in. I mean, we have all the same narcotic rules. Like they have to do count
Mhm.
and stuff like that. When meds come into the program, they have to count them. They basically have to know how to do the med administration part of
Right. Front
it.
and
And
back. Yeah,
like,
because there are all these things that come up and you can't just be like, "Oh, well, I'm not gonna worry about it." No, you gotta do this right. Like, you have to meet these guidelines.
yeah, so
Um,
that's, you know,
yeah.
and sometimes the class teaches them a lot, but it doesn't teach them about the weird discharge at four
Well,
o'clock.
because how
It's
can
like
one
time
class
have
cover everything? Yeah.
bad time discharges. Like that's a thing in the community too.
Yeah,
You
and
know,
a lot of us don't even realize that all this stuff, all the
you would probably have no idea what I was talking about if I called you and said, so this person, they actually live in a group home, and I need the doctor to sign this order with all of their psych and medical medications
yeah.
before they leave,
Yeah,
and I
and
need to
I
send
mean,
it.
the only
That's what
experience I have with that is, like, seeing the orders in the binder, in the
yeah,
kitchen, at the house I worked, with the
yeah,
lockbox, with the meds. Like, yeah, that was my limited experience with it, but it did give me an appreciation for the fact that there is someone that has to make sure that all this stuff is done correctly and safely, because
appreciation, but that's all still on paper.
yeah. Oh, yeah. No computer system, no electronic medical record, and if those
There is
papers get spilled
there's like
on or ripped.
software. There's like an input software where we put all
Mhm.
the information in, but like the sheets, the orders are still physically signed, and the med sheets are still physically signed off on for each shift.
These new nurses, they don't know what paper charting
Yeah.
is like. I
But
did.
then we also have an electronic record where like I go in and write notes. I write more notes now than I wrote when I was in patient.
Of
Our
course. My
doc
gosh.
for the month of July, it's a fourth and a hundred.
That is
And I
insane.
think that was with taking like a week off.
So that
I
was
took,
condensed. That was
yeah,
condensed.
I took like half a week off.
So it's
But
your job is so vast and it's so interesting.
it is,
I do kind of want to wrap things up a little bit because I can smell dinner cooking in the background. That's both the
tough
beauty
to
and the
smell it so
danger. So actually tonight, I'm gonna side note, we ordered one of my favorite chain restaurants from back home. I grew up just outside of Chicago. There's a place called Portillo's, and they do like Italian sausage, Italian beef, cheese fries, like all these beautiful, beautiful things. And they do like a home box where they like send you all of the pieces and
Oh
you like warm it
no.
up and assemble it yourself. Doug got me one of these back in June. It's now September. We've got another box, and this is the first night. We can basically get like 8 servings out of it. So we do 4 nights. We split it in half. It's a big thing. It's an issue here because I don't have a Portillo's in the state. I guess there's one an hour away. But anyway, so it's an exciting night for us. So it's been a really good day, and I'm going to end it by stuffing my face with some Italian beef.
I'm gonna go drink a beverage.
That sounds nice. That sounds nice. I'm really glad that you came back to talk to me again.
I know. I love that.
You're like my friend in community health. Like it's and you're also like one of the top Nursing Uncensored fans. Like I feel like you've been right there from the beginning.
I enjoy it. I just all day.
And I love your support. I love getting messages from you, and yeah, it's really good to talk to you again and to actually
wait till I go to grad school.
Oh yeah, then we'll have so much more to talk about. That's awesome. Well, Renee, do you want to share with our audience your social media or anything, anywhere people can find you?
So I'm mostly just do my Instagram. So my Instagram is still at a little piece of insane.
A little piece of insane. I love it.
Still very accurate. Those are personal, but I also post like all my nurse home. A bunch of nursing stuff on there.
Nice.
Yeah.
Well, Renee, thank you again for joining me. This has been a great episode.
Thank you. I had so much fun. Happy Friday.
Yeah, happy Friday to you too, and happy nursing. Peace. Bye. Here at Nursing Uncensored, we may be, well, uncensored, but we're not unfiltered. Protected health information has been changed and concealed to comply with HIPAA. The things we talk about are from years of experience with thousands of patients, things we've read, stories we've heard. If you think we're talking about you, we're not. Also, we're real nurses here to provide helpful and accurate information, but don't take anything we say as fact without doing your own research. Refer to your state's Board of Nursing, Practice Acts, and your institution's policies and procedures if you have questions about your practice. Lastly, our very strong opinions are ours alone and do not reflect those of our employers, educational, or professional institutions. Thanks for listening, and happy nursing, folks.